right, good afternoon, ladies and gentlemen. First of all, thank you very much for giving me a chance to present here in the University of Kyoto. Um, Today, I'm going to present my research topic that is already published in last year in with the International Journal of Health Service. The research title is The Impact of Community-Based Health Insurance in Enhancing Better Accessibility and Lowering the Chance of Having Financial Catastrophe Due to Health Service Utilization, a case study of Savannakhet Province, Laos. All right, there are four parts in this presentation. The first part is the background, and then the second part is the methodology. The third part is results, and the last part is the discussion part. All right, let's go over the very first part, the background. This research was conducted in Laos, a country in Southeast Asia. As you can see in the map, it is surrounded by many countries such as Thailand, Vietnam, Cambodia, Myanmar, and China. Despite improvement in the last decades, the life expectancy in Laos is still very low in comparison to other neighboring countries in Southeast Asia. And similar to other low-income countries, most of the Lao population still relying on out-of-pocket expenditure in exchange for healthcare services. Today I'm going, and then this slide I'm going to go over the insurance schemes available in Laos. Currently, there are 4 healthcare schemes available in Laos. The first one is called State Authority of Social Security, or SASS. The second one is Social Security Office. Both schemes are compulsory schemes for civil servants and salary workers for private and state enterprise, respectively. And both schemes are operated under the Ministry of Labor and Social Welfare. The third scheme, which we are going to focus, is called the CBHI scheme, which stands for Community-Based Health Insurance, a voluntary scheme for informal and self-employed. This scheme is managed by the Ministry of Health in Laos, and the fourth scheme is called the HEF scheme, which stands for Health Equity Fund. This scheme is very similar to the CBHI scheme. It is the scheme that the government purchased, the CBHI scheme, for the very low-income people, mostly resided in the mountainous area or the rural area of Laos, or in short, for the very, very poor and unaffordable people in the rural area. This research is one of the very first research related to the CBHIs in Laos. CBHI in Laos is firstly introduced in 2004, so almost 13 years ago. But not a lot of study was conducted to assess the effectiveness or the quality of the CBHI scheme. So this study aims to find out if the CBHI members are having better accessibility for inpatient service utilization in comparison to uninsured households, and to analyze the role of CBHI scheme in terms of financial protection against catastrophic expenditure compared with the uninsured household. Now we move on to the methodology part. Anderson behavioral models of health service is well known as a classical reference for health service. So in this study, we use the Anderson behavioral model as a guideline to build the conceptual framework of this study. The Anderson behavioral models comprise of three categories of determinants as followings. The first one is predisposing characteristics, enabling characteristics, need-based characteristics. This is the Anderson behavioral models in detail. So predisposing characteristics refers to the proclivity of utilizing healthcare services. Anderson stated that the demand of healthcare service depends on demographic position within social structure and belief of health services. Enabling factors refer to resource available within family and community. Family resource include economic status and location of residence, whereas community resource involved with the accessibility of healthcare facilities or availability of people for assistance. Last but not least, need-based characteristics is the perception of need for health care services, whether individual, social, or clinically evaluated perception of needs. This slide shows you guys the conceptual framework of the study. Recall that there are two objectives of this study, and in this study we use the logistic regression to evaluate the accessibility to healthcare services and also financial protection against financial catastrophe. Independent variables were derived from Anderson behavioral models. There are three parts I already mentioned before. The first part, predisposing characteristics, composed of gender, age, marital status, educational level, size of household. The second part, enabling characteristics. We have insurance status and income level. The third part of Anderson behavioral model is need-based characteristics, which is chronic condition here. For the dependent variable, we have probability of using IPD services between insured and uninsured households, and probability of suffering from financial catastrophe between insured and uninsured household. Let's move on to the research design. In these studies, we apply a cross-sectional study design. There are pros and cons of using this study design. The pros is it is relatively easy and not time-consuming to get the result done, but there is a disadvantage, which is it is only able to capture the current situation of the CBHI of Laos in the context of Laos, but for the study sites, first of all, in Laos there are 18 provinces. This study was conducted in Savannakhet province, which is the biggest province in Laos. It is located in the central part of Laos, and it is about 500 kilometers away from the capital. There are 15 districts in Savannakhet province, in which only 5 of them were on CBHI, in which only five districts CBHI were only available in 5 districts of Savannakhet province, and the rest 10 were not available yet. From this point, Kesan Phomvihan district and Champon province, 2 provinces were randomly selected from 5 districts to represent the study sites. After getting the study sites, we are able to calculate the total sample size of 252 households. They are equally divided into 2 groups, insured and uninsured households. The data collection process were implemented in hospitals to effectively identify both insured and uninsured respondents from July to September 2013. Both Savannakhet provincial hospitals and Champon District Hospital were taken into account. I would like to tell you that in Laos, in each district there is only one single hospital, so all of them were taken into account here. And the simple random sampling method was used to select the respondents from OPD in order to minimize possible bias related to respondents and their household member health problem. The questionnaire were used as the tool to retrieve the information from both insured and uninsured. In this case, the questionnaire were separately developed for insured and uninsured household. The data analysis and interpretation. There are 2 methods. There are both descriptive and inferential statistics were used in this study. The descriptive statistics were used to present respondent social demographic composition, and the logistic regression was used to calculate the probability of hospitalization, representing the accessibility to healthcare services. And the second model is to calculate the probability of suffering from financial catastrophe. Recall that there are 2 regression models, and then this slide going to present you guys the result of the first model, which is to find out the probability of hospitalization. As you can see from the slide, the p-value here, none of them were statistically significant at 95% confidence interval, but 2 of them here at the bottom, highlighted in blue, are almost statistically significant, which is income level more than 2.5 million kip, or around $300. This slide shows you guys that household income more than $300 or 2.5 million kip have less probability to suffer, have less probability to use health service utilization. And also at the bottom, household with the availability of chronic condition are more likely to use hospitalization. In this in this model, the variable of interest is insurance status, because we would like to find out if insured household are more likely to get more healthcare services. And we can find that the insurance status here are not statistically significant. So we can conclude that CBHI scheme or insurance status do not significantly improve health service utilization. In other words, we can say that between insured and uninsured households are indifferent in terms of accessing to healthcare service utilization. This slide shows you guys the probability of experiencing catastrophic health expenditure. Similar to the first model, we can find out that there are two variables, which is education level lower than secondary school or higher, lower secondary school or higher, have less chance of getting financial catastrophe. This one, and it is statistically significant at 95% confidence interval. It means that households with relatively higher level of education have less probability of getting financial catastrophe compared to the household with lower education level. For the income level, households who have relatively high income are less likely to suffer from financial catastrophe, and it is statistically significant here. Similar to the previous slide, the previous model, we can find out that the chronic condition also play the important role of suffering from financial catastrophe. But it is not statistically significant at 95 confidence interval. And once again, the variable of interest is insurance status. And once again, it is not statistically significant at 95 confidence interval. And from this point, we can say that the CBHI scheme or household who have insured are not having financial, not having better financial protection compared to the uninsured household at 95 confidence interval. Let's move to the discussion part. From the logistic regression model, we could find out that the logistic regression model showed that even though variable was statistically significant, we could find that the smaller households were marginally more likely to be hospitalized. This study was similar to the previous study conducted earlier, which state that respondents in the larger household were usually unable to afford healthcare services. The result also shows that the respondents with chronic disease were not likely to be hospitalized, since households understand their health condition and their intention to purchase insurance service is positively correlated to the risk of loss. In other words, individuals who have high probability of using hospital service are more likely to be insured. The results of the regression model shows that insured respondents were more likely to be hospitalized, but the p-value is not statistically significant at 95% confidence interval. So we can conclude that this study is not, the CBHI is not able to constitute a significant impact of the health service accessibility. In terms of, let's go over the discussion part of the regression model too. In terms of insurance, in terms of income level, it reveals that respondents in lower income quintile are more likely to be hospitalized. The reason supporting this is relatively simple, as catastrophic health expenditure refers to total out-of-pocket payment equal to or more than 40% of household income minus subsistence needs. So poorest income households have higher probability of suffering from financial catastrophe. Chronic condition is another factor that lead to catastrophic expenditure. The result of those logistic regression showed that respondents with chronic condition were 3.5 times higher probability to experience financial catastrophe in comparison to those who do not have any chronic condition within their household. Similar to logistic regression model 1, the variable of interest is insurance status. And this study shows that the insured household have less probability of experiencing catastrophic expenditure, but not statistically significant. All right, that's all for the presentation. Thank you very much.